I'm a rheumatologist, and I'm going to teach you to differentiate calcium pyrophosphate deposition from gout. Gout and CPPD are both types of crystal arthropathies, meaning inflammatory arthritis triggered by crystals. They both can cause redness, heat, and swelling of the joints, but this is how you differentiate them. Gout typically initially attacks the great toe. Over time, it can progress to affect the other joints as well, but it usually starts in the great toe. Uric acid is the crystal that causes gout, and its solubility decreases at lower temperatures. This makes crystallization more likely in cooler joints that are farther from the body's core. The great toe is particularly vulnerable because of that low temperature and because of repetitive microtrauma. CPPD typically affects the knees and the wrists. The reason why is that calcium pyrophosphate crystal formation is driven by dysregulation of pyrophosphate in the cartilage rather than by a decrease in temperature. So this type of pyrophosphate dysregulation can happen as we get older, and it can also happen because of metabolic conditions like hyperparathyroidism, hemochromatosis, or hypomagnesemia. It can also happen because of genetic factors affecting the ANKH gene. The knee and wrist are joints with high metabolic activity and cartilage turnover, which is why they are affected more. Gout can occur in younger men and also can occur in postmenopausal women, while CPPD typically happens in older people over the age of 70. If you see CPPD in a younger patient, you want to look for secondary metabolic causes like hyperparathyroidism, hemochromatosis, and hypomagnesemia. On X-rays, the hallmark finding of CPPD is chondrocalcinosis, which is linear calcification that looks like a bit of icing on the cartilage. The most common areas to see this are in the knee menisci or in the triangular fibrocartilage of the wrist. Early on in gout, the X-rays are typically normal, but over time, you might see buildup of those uric acid crystals into soft masses called tophi, and you can also see erosions that look like little bites into the bone that reflect damage from that ongoing inflammation. Uric acid can be elevated in gout, but it is not always elevated during an acute flare. The reason for this is that the inflammation causes an increase in uric acid excretion into the urine. You can also have a patient who has CPPD and asymptomatic hyperuricemia, meaning they just happen to have elevated uric acid. So you should not base your diagnosis on the uric acid alone. The gold standard is to take some fluid out of the joint and look at it under a microscope. Now, birefringence describes how crystals interact with polarized light. Different types of crystals act like a prism and split and bend light differently, making them turn different colors when you rotate them. Positive versus negative birefringence simply describes which direction the crystal is pointing when it turns blue. Gout crystals are negatively birefringent, meaning they turn yellow when pointing up or down, meaning parallel to the filter, and they turn blue when they're pointing left to right or perpendicular to the filter. CPP crystals are positively birefringent, meaning they turn blue when parallel to the filter and they turn yellow when perpendicular to the filter. Urate crystals are needle-shaped, and they are usually very bright and easy to see the color changes. CPP crystals are usually rhomboid or diamond-shaped, and the color change is typically a bit harder to see.